TopMedTalk.
Well, hello, I'm Desiree Chappell, and this is TopMedTalk. We are live from the European Anesthesiology Congress, EUROANESthesia 2019 in Vienna, and I'm here with Editor-in-Chief of TopMedTalk, Monty Mythen. Hello, Monty.
Hi, Desiree. We're having a busy day. It's good.
You know what's funny is I tried not to schedule too much, but
You said that we would be allowed to at least go to the bathroom every now and again, but that's been a false promise.
It is, I know, I'm
But at
sorry.
least we're not drinking anything, so we're not hydrating. So
Could be an issue later
we
on.
have no need for that. So.
Well, we've met up with some new friends, but we've also been able to catch up with some old friends too, and we have our guest with us this afternoon, Frederic Michard, who is a guest and a very special friend. Frederic, how are you?
I'm very good, Desiree.
Good. So
Nice to see you.
It is very nice to see you. Thank you for coming and sitting down with us. And I know that when we caught you, you were in a rush because you were just coming from a session that you were doing. So
Yeah, I'm sorry I was a bit late, but
no.
It was a busy session with many questions at the end.
That's always a good sign.
Exactly.
Yeah.
A lot of interest. It was a session about computers,
Yeah.
how computers could help us during surgery with closed loop system, but also after surgery. I was giving a lecture on wearable sensors for monitoring patients on the wards.
Yeah. So remind me the title of your presentation that you're doing.
Was wireless wearables for the wards, like the new WWW revolution question mark.
I love it. I thought when you said that to me, I'm like, that's so awesome. The WWW, the new revolution. I think it's going to be good. I know we've talked about this before, but I think it definitely warrants talking about it again. Can you tell us a little bit about what's going on in that space and what we can expect to see?
Yeah, so I used in my presentation a very recent paper published in the Lancet. It's a very short paper, but they look at the global burden of surgery of post-operative complications, actually. And they claim that there are 4.2 million patients who die within 30 days following surgery on the planet every year.
Wow, that's huge.
It's huge, and this is actually the third leading cause of death.
Yeah,
That's what they claim.
We talked about that.
It's
Yeah.
more than HIV.
Exactly.
It is.
More than HIV, malaria, and tuberculosis combined.
Combined, right, yes.
Yeah, so obviously
that
this paper.
paper.
So it's a very powerful paper and statement, of course, very useful to start and kick off a discussion on the topic.
But the suggestion is that much of that is avoidable. Otherwise, there's a balance. Because sometimes you need the surgery to try and save your life, and part of it is your life may not be savable.
Of course,
Yeah.
we are not going to be able to prevent all these deaths, but some are preventable.
Yeah.
We know that there are many medical complications we can prevent by improving the way we manage patients during surgery, but also, and that was my point, by improving the way we monitor patients when they are on the wards.
Yeah.
Because in the OR, in the PACU, we look at them very closely, we monitor vital signs continuously, but as soon as they reach the wards, as you know, nurses are doing spot check every 4 to 6 hours, and 5 minutes every 4 hours, it's actually 2% of the time. During my lecture, I was highlighting the paradox that today, with your smartphone, we can and connected device. I have a few, as you can imagine, in my home. I'm playing with all the time, and so that's the paradox. We're about to reach that we can monitor a lot of information or collect a lot of physiological information from home, and the paradox would be as soon as we are admitted in the hospital, then nothing.
Yeah. Well, I was just going to say, my dad gets a little alert when his heart rate drops, or on his watch, but we can't get monitoring in the ward. It's crazy to me.
So that was basically the point I was trying to make, to show that because we developed so many efforts and energy to improve quality of care during surgery. So we had two great speakers explaining that when using closed loop system for fluid administration, for anesthetic management, we can possibly improve outcome, but I would say improve outcome a little, as compared to what we could possibly do if we were investing more energy and imagination to monitor patients on the wards. Because, so I said, many patients die after surgery. What I didn't say is that the second slide of my presentation is actually the large EUROANES study, also published in the Lancet in 2012 by Rupert Pierce, showing that most patients who die after surgery, they don't die in the ICU.
No.
They die on the wards.
Yep.
And as an intensivist, I tended to believe that when patients are deteriorating, on the wards, they are transferred to the ICU and eventually die in the ICU.
Yeah.
But I realized when reading these articles that actually most patients die on the wards.
Yeah.
That's why I'm convinced we need to find a solution to improve the detection of clinical deterioration.
So part of the thing I'm struggling with at the moment on that journey, so I completely agree with you, but therefore what we've got to do is to help people to understand the value proposition of the monitoring on the ward, such that they accelerate more towards accepting that solution. Now, I've seen some presentations recently where people have kept lots more patients in the overnight intensive recovery area to demonstrate how unstable the patients are that are going back to the floor. And as a result of that, the managers are turning around and saying, well, we can't keep everyone here. And you say, well, we know that, which means we have to have a solution that works on the floor. And they're making sense in that. They're not necessarily, they want to make the jump straight to the wireless, but the value proposition for that at the moment is quite complicated. Because I think I'm increasingly believing we might have to keep some people in a sort of high dependency type of area to demonstrate the need for the wireless monitoring. So one example I saw from Guy Ludbrook and Bernard Riedel presented in New Zealand recently was when they did that, they detected 25% more hemodynamically unstable patients. So 30% of the patients were unstable post-operatively. If they went back to the floor, only 5% of those were detected.
Yeah.
So,
Yeah. It's a very good point. By the way, Desiree, you were asking me what's new since we met and discussed last time. I think it was during ASA in Chicago. So I mentioned this paper in the Lancet, 4.2 million patients. There is also a very interesting paper from the group of Dan Sessler published in Anaesthesiology, where they monitored blood pressure continuously and non-invasively on the wards. And clinicians were blinded from the measurement. So nurses were doing their regular spot check of blood pressure with a brachial cuff every 4 hours. And then they finally looked at the continuous monitoring data to realize that they missed around 50% of hypotensive events. And what's interesting in this study as well is that when they say hypotensive events, it's pretty serious because it was a map below 65 for at least 15 minutes.
Okay,
so that's that's clearly something, and that's the illustration of what you were saying.
It is. I kind of, because I was thinking like you, we'll be able to get the people to jump straight to the wireless monitoring. A few places might have to demonstrate with good old-fashioned regular continuous monitoring, which will be quite expensive to deliver, but the technology's there to make the people who cut the checks turn around and say, whoa, hang on a second. I can see that there's a problem that wasn't being detected. Now let's invest in the wireless solution so it's detectable. Otherwise, we're going to have to try and jump them forward. I'm not sure we can make the jump. I hope we can make the jump straight to wireless, but I think we might have to put the painful step in before.
I'm not sure, because at least from a technological standpoint would be a big challenge, because the technologies we have and we use today in the OR on the PACU is definitely not convenient to monitor patients on the wards. So,
but that might drive the value proposition. So what I'm getting, I'm not expressing it very well, is if when they kept people in recovery and they either left the arterial lining or they left something like the ClearSight monitor or other continuous non-invasive monitors, which are, costly. The manpower to monitor them is costly. They demonstrated all the problems that weren't being seen. Yeah. So then when they do that, they have a value proposition there, but they also turn around and say, this is why we have to accelerate towards the wireless solutions.
Like, we actually have a problem.
We have a problem. Yeah, Houston, we have a problem. Here's the problem.
Yeah.
Don't deny the problem by sending people back to the floor.
Where, I can totally see going to my administrator or going to an administrator and say, I think we have this problem, but we can't really show it. And it's hard to build a value proposition to spend, hey, let's invest all this money in wireless technology. We don't have a problem.
So keep 60 consecutive patients overnight in recovery, monitor them continuously, which is hard work, which is what they did, and demonstrate that 1 in 3 is getting into trouble, whereas you thought it was 1 in 20.
Yeah.
And then they can turn around and say, now I hear you. It's a problem we have here.
So, Frederic, what does the wireless technology look like that is in the wards? I mean, is it as simple as a patch, a watch? It
could be basically everything you can imagine. There are necklaces which are already FDA approved. I mean, in the US,
really?
Yes, we can't use them in Europe, Desiree, but you could use them
which
in
is usually
Louisville.
Odd, right? That we can actually use it here, then you guys can't use it?
There are necklaces monitoring heart rate,
Is it
respiratory rate, and these are bioimpedance necklaces.
Okay. That's what I was going to ask.
So they can also detect a change in thoracic fluid content. So, by the way, I mean, most of these companies are not focusing today on post-operative patients. They are focusing on patients with congestive heart failure, for example, and home monitoring.
Yeah.
That could be a way, if you detect pulmonary congestion at a very early stage, to modify therapy and prevent hospital readmission, which is a big issue, not only clinical and human, but also economical in the US.
Yes.
Readmission for congestive heart failure.
Yeah.
And as you said, I mean, there are many adhesive patches you can use today to monitor heart rate, respiratory rate, possibly SpO2, skin temperature.
Yeah.
And so basically all vital signs, I think, we'll be able to monitor them continuously with simple tools.
Do you think that that technology, I mean, how long does it last? Like if we put somebody immediately post-op on this, that they can go home with it and use it for extended periods of time? And do you think it's going to change like length of stay or anything like that people would be able to be discharged because we're going to send them home with this more?
Could be an additional benefit. I always have a question about home monitoring, but my answer is usually, I want to focus first on what's happening in the hospital because it's a well-controlled area. And I think we learn a lot, by the way. We don't know anything. If I don't know if you tried yourself, but if you monitor your blood pressure continuously, you are clearly surprised, right? Actually, I was surprised to see that all these swings, from the morning to the evening, and we tend to believe that we have one usual blood pressure value, and we know it's actually, when we use these tools, it's definitely not the case. Yeah. Same for blood glucose monitoring, same for basically all physiological or biological signals. As soon as we are able to monitor them continuously, we learn a lot about physiology. So I think it's definitely too soon to envision monitoring from home. I know many companies are, of course, interested because that's the big market.
Yeah.
Many people are interested as well. Yeah. But as you know, usually people are interested, actually probably not the people who would benefit from them.
Right,
okay?
Exactly.
They are very fit people, they monitor the heart rate, they even monitor the SpO2, and what's the point measuring your SpO2 when you play tennis? Or I have no idea.
You run 1,000 miles, like who cares? Yeah.
But when you have COPD and or asthma, it could be interesting to have these sensors giving you information about your respiratory rate and your SpO2.
I think the entrance into that, though, the technology that's come out with monitoring continuous blood pressure or blood glucose and things like that, like people are kind of getting used to that tech. So maybe that will be the kind of, the next step. I can see that kind of helping to be a bridge to understand, like, going to be continuously monitored. I can look on my phone and see what it is, and I can send that to a physician if I need to. So that's interesting. I don't know.
And the potential for information overload.
Yeah.
So I presume part of it is information filtering and analysis and predictive analytics or responsive artificial intelligence. Because otherwise, like you said, with the blood pressure signal, it's all over the place. So you need to kind of filter out.
It's but I think we need more than computers. We need first of all to be able ourselves to interpret the measurements, and then of course computers will be able. But we will need them to filter artifacts, to ensure we get reliable information. But I think there is clearly a phase where we will have to better understand what's happening, what should be done.
Yeah.
And probably, significant changes have to be respected because they just reflect normal physiology.
Yes.
And I'm always a bit scared when I see young doctors obsessed by the normalization of blood pressure, cardiac output, whatever. I think so very often we have to respect what's happening, particularly in ICU patients.
Yeah.
Because it's very often just a response to the aggression.
Well, it's always like I have to give some medication to treat some. I have to treat the number, not looking at the patient. It happens for sure. Well, Frederic, thank you so much for sitting down with us. I know you just got out of your session. You've been talking all afternoon, but I do appreciate it because it's a hot topic, and we're going to be talking a lot more about it. And hopefully you'll be able to come back and tell us some new technology coming out here. You always seem at the forefront of all this stuff. So.
Always a pleasure to stop by TopMedTalk booth.
And where do we find you again and find your information? You told us before, but where should we look you up?
Oh, the easiest way to to follow me is actually to visit my website, michardconsulting.com.
MichardConsulting.com.
MICHARD.
Yes.
Right.
Consulting, all one word?
Yes,
Yeah.
one word.
One word.
.com.
We'll get
Okay.
that in the show notes.
We will, for sure.
Thank you very much.
Thank you so much.
Great
Thank
to see you.
TopMedTalk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out TopMedTalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. TopMedTalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.